IC. I think for the first talk, Dr. ROHITHA will be starting. We'll be talking about the topic IOL power calculation in cataract with keratoconus. Dr. ROHITHA, please.
Thank you. Today I shall talk on IOL power calculation in cataract with keratoconus. Just a few points. Keratoconus is a progressive disorder characterized by thinning and protrusion of the cornea, resulting in decreased visual acuity and irregular astigmatism. The basic criteria all of us know is the Rabinowitz index, which has the central steepening of around more than 47.2, and the difference between the inferior and superior will be more than 1.2, and a steep radial axis skewing of more than 22 degrees. The other commonest classification is the Amsler classification, which is based on the amount of astigmatism, basically the refraction, the central K readings, presence or absence of scarring, and the corneal thickness. There are a lot of other classifications, but it is out of scope for this discussion. What we should look for? Initially, I shall tell a few points about the pentacam, only basic points. That is the inferior steepening, posterior elevation of more than 17 microns, anterior elevation of more than 12 microns. Coming to the Bellin-Ambrosio display, we have the first two maps showing us the anterior and the posterior elevation, which is based on the best fit sphere. The second two maps shows us the enhanced best fit sphere, the elevation based on that. And the last two maps shows us the difference between these two. We all know the dependence of keratoconus patient on the contact lenses, but chronic usage of contact lens causes warpage, which will interfere with our topography. There is no hard and fast rule to each surgeon differs with the contact lens holiday, which is required for all the calculation. This is just a rough guide which can be followed. Coming to the role of corneal epithelium, we all know corneal epithelium remodeling actually happens at the area of stromal thinning. Reinstall et al. Have done a lot of study on this, and have shown that in keratoconus, the thinning of the epithelium is present in areas of relative increase in wherever the cornea is very steep, and wherever it is relatively flatter, it actually thickens. Basically, the inferior paracentral region. So that is why the epithelial profile in KC will be basically a donut shape. So in case the corneal epithelium is irregular, we based with the Trehalose based lubricant eye drops and treatment of any dry eye, we try to regularize it. Trehalose is used even sometimes after KXL, because it increases the epithelial remodeling which can happen. When we should operate in a KC, any visually significant cataract, age more than 40 years, it is not a important criteria, because even if it is significant in a lesser than 40-year-old, we have to go ahead. And in case the patient is less than 40 years, we need to explain the chances of progression. And the most important thing is having a stable keratoconus, where the corneal Kmax is less than 1 diopter difference between at least for a period of 6 months. This is our approach. First, we have to find out whether the KC is stable. If it is not stable, we do epithelial mapping, and if it is irregular or thickened, we give them a month's treatment on a Trehalose-based lubricant. If to regularize it, either if we see whether the cone is centered or decentered, and act accordingly. And the details of the whole discussion about the treatment and approach for keratoconus treatment is out of scope for this discussion. This is what is required for a cataract surgeon based on the severity of the KC. If it is a mild KC of less than 48 diopters, we can actually use the K value for all our calculation and target a low myopia. If the axial length is less than 25 millimeters, or wide to wide is less than 12.5, we can plan toric or monofocal. If it is a larger axial length, or if the wide to wide is large, meaning that the bag is larger, we may need to consider a CTR if a toric is planned. In cases of severe K, we can plan a toric, but it has to be customized toric. And if there is very severe scarring and we are unable to acquire proper scan results, we can use the standard K. So coming to why are IL calculation in keratoconus so challenging? First is we are here dealing with the very irregular astigmatism. That is, the ratio between the central K and the paracentral K is not regular, causing tear film abnormalities, which leads to poor repeatability of all the biometric findings. Most of these patients have not only a difficult K, they have longer axial lengths and they have a very deep anterior chamber. All this causes a hyperopic estimation of the IL power with normal biometry. Coming to assumptions. For normal IL calculation, the assumption between the anterior and the posterior corneal curvature, that's basically the Gulstand ratio, which is supposed to be 82%, is not according in keratoconus. So because of posterior thinning, this ratio is altered. One more thing is, normal corneal refractive index is 1.376, but we use a keratometric index of 1.3375 for all our IL calculations. And this keratometric index will also be altered because of posterior corneal thinning, which leads us to the second most important thing, is measuring the posterior cornea. So these are the two common instruments which can be used. This is the IL Master 700, which gives us the posterior cornea, which also measures the posterior cornea, and the Pentacam, which measures the posterior cornea. Pentacam gives us different K readings. It gives us the SIM K, it gives us true net power, total corneal refractive power. Here we should note that SIM K is the only one which uses the refractive index of 1.3375 and so can be used in all older IOL calculations. Whereas the TNP and the TCRP, they are based on the actual corneal refractive index of 1.376 and therefore cannot be used. Coming to the Holiday EKR report, which gives us the zonal K readings, this is based on refractive index of 1.3375 and therefore the central 4 to 4.5 millimeter zone K can be used for our IL calculations. Coming to TK, or the total keratometry on IL master. It gives us both the anterior and the posterior curvature. The anterior is measured by telecentric keratometry, whereas the posterior cornea, it is measured by a swept source OCT. It doesn't directly give us the posterior and anterior algebraic sum. It actually modifies what it calculates for the posterior with an algorithm and changes the posterior K to the refractive index of 1.3375 so that it can be directly used for our IL calculations. The advantages of IL master is repeatability of the scans and the rapid acquisition of the scans. Both eye scans can be done in less than 45 seconds. Coming to choosing the right IL formulas, I hope everyone knows who are these people. Coming to the basic two-variable formula, that is the SRKT formula. SRKT has been found in many studies to actually give us better results than other older generation formulas because of its inherent design flaw. That is, in normal eyes, it actually gives a myopic shift. As we all know, in keratoconus, we have a hyperopic IL biometry. It just compensates for the thing where Haigis called as to be a cusp phenomena. Coming to IL formulae, which are specifically designed for KC, is the Kane keratoconus, the Barrett 2K KC, and the Holiday 2K KC. I shall talk about the first two. The Holiday is a paid software. Coming to Barrett-True-K formula. The Barrett-True-K is basically based on the universal 2, but where True-K is modification for post-refractive eyes. KC is also quite similar to post-refractive eyes in a way that the anterior and the posterior ratio is altered. This formula uses a double K method to improve the ELP. That is, it uses the measured K for IOL calculation and a theoretical K to derive the ELP. It employs the, even in True-K KC, it employs the measured posterior cornea. In case we have biometry which do not give us a posterior cornea, we can use the theoretical prediction and enter only the anterior K values. It is more conservative than Kane KC because it is closer to IOL recommendations which is given without KC adjustment. The mathematical formula for this calculation is not yet published. If you go to ASCRS website and try, the keratoconus does not appear in the drop-down menu. We need to go to APACRS website to find the drop-down menu. Coming to Kane formula, a lot of studies have shown that it is the more accurate over all other modern formulas. It is based on a regression analysis of a large data sets and artificial intelligence and theoretical optics, and uses even the CCT and the gender for IL calculation. The difference between Kane formula to Kane keratoconus formula is, in Kane keratoconus, he uses the anterior corneal radii of curvature to derive a modified corneal power. We have to enter the anterior corneal values and it theoretically derives the net corneal power. In the this can be got from IOLformulae.com, and the K1 and K2 up to 65 diopters can be entered in Kane formula, while as in Barrett-True-K it is up to 60 diopters. There is a target refraction to be set. For less than 48 you can keep it unchanged. For up to 59, around -1 can be the target refraction, and more than 59 up to 2.5 can be the target refraction. In advanced keratoconus or in areas where scan acquisition is difficult, or in scarred corneas, we can use the keratometry from the other eye or use standard K values for IOL calculation. Coming to which IOL would you choose? We all know that the central cornea is steeper than the peripheral cornea, which gives us a prolate cornea which has a Q value which is negative. In keratoconus, this Q value is altered and becomes more negative. So we need a IOL which is at least a zero or a positive spherical aberration. Coming to toric IOL keratoconus, in mild to moderate keratoconus with a relatively irregular central astigmatism, toric IOLs can be given as a choice. And in patients whose vision can improve for more than 6/12, we have to tell the patient that it is just an astigmatic debulking procedure and we cannot correct the total astigmatism. We have to watch for progression after cataract surgery, and one main thing to note is if the patient is already happy with the scleral contact lens and with the RGP, please do not provide toric, give them monofocal and correct the residual with the scleral lens and RGP lens, because they are used to some lens being on the cornea than in front or behind. This is a case example. So 55-year-old with grade 1 NS to PSC. We can see the inferior steepening in the first graph. The posterior elevation is around 98 microns and the anterior is around 23 microns. The EKR is giving us a reading of 47 and 51. Coming to epithelial mapping, we can see that the cornea here is quite regular. The IOL master K is around 50 and 58. So these are the comparisons where anterior K, sim K and the EKR. Barrett through K using the K, anterior K from the IL master and the biometry, it is giving us a plus 8.5, whereas Kane using the same parameters gives us a plus 10.5. It is always better to go in for a higher IOL power because it at least gives us a myopic target, or even if it overcorrects, it will give us a residual myopia, which is good. And any residual refractive cylinder can be corrected with the scleral contact lens, which the patient was already using. Thank you.
So, meanwhile, till Dr. Aishwarya comes on stage, see, one of the things which, while treating KC, some of us, what we do is we look at the book. No, we have to look at, refraction stability and then do the surgery, cataract surgery. Please do not have that in mind, because refraction stability, you cannot have that as a factor in when the patient already has cataract. Because of the cataract, the refraction will keep changing, so don't keep that into consideration. Always look for the scans, look for the repeatability of the scans. Once you do multiple scans, it looks like it's not changing. These are all the things which I'm telling about in young patients. In older patients anyway, usually the KC is already stable, so you don't have to worry about it. To just Dr. Rohitha's talk, basically if you have a KC, you grade the severity, and only in severe cases you can use a standard K, otherwise you go with the actual case. And among the formulas, Kane does extremely well. IOL Master, even if you are not comfortable with Kane, it's okay. IOL Master does a fantastic job. And one of the questions which normally we keep getting is, see, I don't have a machine which measures the actual K, the posterior cornea, like the TK of the IOL Master or something like that. Is it okay? Yes, it is fine. Don't worry about it. You can still go with the online calculators, but there is a difference between the two, especially in these irregular corneas. The difference slightly stands out more as compared to regular scans, regular cataract surgeries, because the actual measurement of the cornea is always a little more superior to the theoretical assumption of the posterior cornea. I think with that said, I think we can go to the next talk. One more point I want to specify, very, very important, is the epithelium in these kind of cases usually is irregular. Always put them on some kind of a lubricant, make the surface more healthier. Automatically in 1 month, believe me, you will see a beautiful change in epithelial remodeling, and you can see this change at 1 month when you do the scan. And then you'll have much more reliable scans, and you'll have much better results. Dr. Tejal, you want to